Never thought I would be sitting here doing what I'm doing. I've thought about medical school since I was 10 years old, and that's the career I want. I look in the literature and was shocked that there was almost nothing out there.
Millions of women reach midlife, start experiencing symptoms of menopause, and still don't get the care they need, even after seeing a doctor. So it's no surprise that Midi Health, a company built to address this gap in care for women, is now serving over 25,000 patients a week in all 50 states. I spoke with Dr. Mindy Goldman, Midi's chief clinical officer, who spent decades in academic medicine building programs for cancer survivorship in women before stepping into the startup world. Now, Dr. Goldman is helping create a new kind of care model for women and training hundreds of providers to do it at scale. Well, Mindy, thank you so much for joining me on the podcast today. I'm so excited to talk to you.
Well, I'm really excited to be here. Thanks for asking.
Yeah, of course. So many interesting things that you're doing and that you've done in your career. One question that I have for you at the very beginning is, did you always know that you wanted to be a doctor?
No. I realized I wanted to be a doctor when I was 10 years old, and I ended up having an appendectomy. And when I was in the OR, the surgeon was a friend of the family, and he let me go into the OR awake and looking around and talking to people. And I was really scared because my parents weren't with me, and I thought I was going to die. But I remember before going to sleep thinking that if I survive this, I want to be a doctor.
Wow, what an incredibly formative experience.
Yeah, when you're young and you have those experiences, they stay with you. And I feel like we all have formative experiences, and sometimes if you listen and you take things from them, it can really change your life. In fact, I know we'll get into more of what I'm doing now, but I would tell you that it was experiences that I had that were meaningful, that I listened to, that allowed me to entirely change my career focus.
I love that. And yes, we're definitely going to get into a lot of those key moments in your life, but I love that twist of listening to the experiences. I think a lot of us have these experiences and have fate grabbing us by the shoulders and shaking us hard, and don't necessarily listen to that sometimes.
Yeah. We're busy, we're too occupied with other things. And sometimes I think if you can step back and sort of take a moment to reflect on it, it has the opportunity to change things in a meaningful way.
Yeah. So fast forward from 10-year-old Mindy, you're wrapping up college and you're finishing up medical school in Vermont. What made you choose gynecology and OBGYN as the field that you were going to step into and spend your career working in?
I was one of those medical students that liked every rotation I did. In fact, as a fourth-year medical student, I even did a sub-I in psychiatry because I enjoyed that so much. But I tried to understand what was important to me, what my personality was like. I realized that I wanted to do something surgically, so that at least narrowed things down. I realized that I wanted continuity of care because when it came down to it, I like fast-paced things where you need to be able to make a quick decision and act on it. And I think oftentimes that leads people to emergency medicine or OBGYN. And I realized that with my personality, I really wanted that long-term patient contact and long-term follow-up, and that the ER, although suited to my personality in some ways, probably wasn't the best career choice to make. And then ultimately, when I was on OBGYN rotations, I just felt this is right.
Hearing you put it that way, it almost seems like, other than a field like maybe med peds, it almost seems like one of the few fields where you could really form a patient connection and care for that patient throughout their entire lifetime, plus have this like emergency sort of trauma, acute sort of interacting with moments to spare element also.
Yeah, really, really special. I feel like it's very broad and gives you lots of things that fill you up.
When you were starting your training, finishing your training, what was the career that you were imagining for yourself? Because I know there's a shift that came later once you were in that career. But what was your sort of original vision for how your life would play out?
Well, let me tell you sort of how I got to California and then kind of what UCSF led me to think about for my career. As you had mentioned, I did medical school in Vermont. I'm from Maine. I had actually done a couple years before medical school doing research, and my college friends were in the Bay Area, and I actually came out to the Bay Area and got a job at UCSF. And for a short bit, I was trying to decide, do I want to do a PhD in research? Would I want to combine it with an MD? And really it helped firm up for me that, yes, I've thought about medical school since I was 10 years old, and that's the career I want. One of the things that really intrigued me and I loved at Vermont is it's very clinically oriented. So you got actually an extra 6 months to do clinical rotations where I could travel the world. I went to London and did a rotation there. I traveled different places in the States, including coming out to California. And I did a rotation at UCSF. And one of the things that it's certainly an incredible institution, but one of the things that really was appealing to me was the diversity of patient population. And I felt like in Vermont, it was a relatively uniform patient population. And I felt that diversity was really important to me, as well as UCSF had sort of every type of training site that I might encounter as a practicing physician. They sent people out to private institutions, to a place like Kaiser, many different, a county hospital and a big academic university hospital. So I felt like that exposure would really give me the opportunity to figure out what type of career do I want to have. When I came to a place like UCSF and I did my residency, what I realized is I loved the academic environment. I loved teaching and that I wanted to stay in academia. So I was lucky enough to be offered a job at UCSF. And I envisioned my career being primarily a teaching faculty, which I have been. And I think I was sort of being groomed to potentially be a residency director one day. I loved kind of supporting and teaching med students. And as I became a senior resident, supporting and teaching our junior residents. And I felt like inside of me, that was probably the right track and something that I could shoot for.
Mindy, it doesn't surprise me to hear that passion that you felt for teaching because you have such a way with people and such a way for telling stories. So that makes a lot of sense. I wonder, when you were at that phase in your life and planning to stay academic and sort of keep your flag academic and really make your legacy, sort of Mindy as a program director and one who sort of directs training, what was the core clinical passion that you had at that time? And I ask because I'm trying to connect the dots to what brought you to your real clinical focus now.
Yeah. I would say I was a true generalist. And I think being a true generalist, I really loved every aspect of OBGYN. And I think in that role of being able to support people, if you're a true generalist, you can support the varied interests that trainees have. Because some people in OB-GYN are going to end up going maternal fetal medicine or reproductive endocrine and infertility or GYN oncology. And I get that because I loved all aspects of that. At that time, I really would say I didn't have an area that I felt like, ooh, this is going to be my expertise. I truly felt like I made the right career decision. I love all aspects of the career that I get to do.
You've spoken publicly often about something that happened with your dear friend, Marina. Would you be able to sort of share how that shifted your focus in life and where the rest of your life would take you?
Sure. I never thought I would be sitting here doing what I'm doing at that point. And Marina was my dearest friend and a family practice physician. She was from Hawaii, and she had not even had her first mammogram when she felt a pretty big lump. At the time, I'm very thankful that I didn't know everything that I do know now about breast cancer. At the time she was diagnosed, I really didn't know how bad it was. and now I do. And I probably would have seen the trajectory of what was going to happen sooner if I knew, and I'm very thankful that I didn't know. So she had a really aggressive triple negative tumor and was diagnosed and really advanced disease that even short time after completing chemotherapy came back. And she died pretty quickly. She died in around, well, all of the details even get a little bit murky, but about 1.5 to 2 years after diagnosis. And I was really involved in her care. I helped to facilitate getting her care at UCSF, and she got incredible care. Some of the things that started changing my focus was I was deeply involved in helping care for her with her partner. I did support groups. When she got really sick and went on hospice, I actually went on leave of absence and moved to Santa Cruz, where she lived, to help take care of her with her partner and family. While she was in treatment, one of the things that she did, being a Western-trained physician, she knew nothing about integrative and complementary care, and nor did I. And UCSF had a Osher Center for Integrative Medicine. And she started seeing a provider there and then in his practice. And she started doing a lot of integrative therapies that I really saw it improved her quality of life and really opened my eyes to more holistic ways of being a provider. I truly believe that the therapies that she was doing improved her quality of life throughout her treatment. It gave her the energy to work out in the gym, which we know is hugely important for cancer survivors, but it was really important for her overall quality of life and mental well-being. So while she was sick, her partner and I decided to work with her to form a nonprofit, because this was in the 2000s. She died in 2000. At that time, there was very little insurance coverage for integrative therapies. There still is limited coverage, but a little bit more to this day. So we were hoping to do this with her in forming a nonprofit organization that would support breast cancer survivors to use complementary and integrative therapies to improve their quality of life, sort of augment the treatment that they were giving. When she passed, we decided that that was like the calling. What we wanted to do was to set that up in her memory. And we actually ran that for 20 years up until COVID. And we provided a lot of funding. We directly gave women with breast cancer funding to use for integrative therapies to improve their quality of life. It was incredibly satisfying, her family as my family, to be able to help run that organization in her honor. In her memory. His was an incredible gift, and we truly helped many, many, many women. When I came back to work, I realized that experience was so profound to me. And when I said things happen and you sort of learn from them, it was a pretty tough time in life. I had also, a number of other things had happened. I had an aunt that was like a second mom to me, and she died in that time period. And the anesthesiologist that I had helped arrange to do Marina's surgery committed suicide. And it was a real tough time. And I luckily got connected with a really very, very good grief counselor to help me out. And I can tell you the exact location where I was. I was at a red light. I was turning onto a specific street when it just sort of came to me that you are supposed to change your career. You are supposed to use this experience and focus on providing care to cancer survivors. It just, I don't know how else to say it other than something like came to me, and I listened. And when I was coming back to work, my thought was, boy, I'd love to work in the cancer center, maybe a half day a week, and learn more about what cancer survivors go through. I saw it with Marina, but she was also really sick most of her treatment course. She was going through active therapy. I didn't really understand a lot of what is survivorship. And at that time, and this is now in, again, the early 2000s, one of the problems with our breast care center at UCSF is a lot of people were going through treatment, and luckily most people do well. We know if cancer is in early stage, the vast majority of people do well, and at 5 years, survival rates are very high. Most people were living with breast cancer, and they were having a tough time getting new patients in. So as the gynecologist is coming to them saying, hey, could I work side by side with you for a half day a week and learn more about cancer? They were sort of looking for someone to do follow-up care, sort of assessing healthy breast cancer survivors, making sure they don't have reoccurrence. And that was sort of what they were looking for in a provider, and I come along. So our department sort of negotiated, and they actually decided to put me there more than I had thought I would do, and give me a 50% position in the breast care center. That meant a lot of things. As I got into the breast care center, it was really emotionally hard to be seeing breast cancer patients and doing obstetrics. Sort of the extremes of that was really emotionally difficult. And I also, as I was in the breast care center and learning more and more about cancer care, I realized that that really was my calling and I wanted to do that more. So I had only been out of my training for a few years, and I made the decision to give up obstetrics. So I loved, when I said at the beginning, I loved being a generalist. I really loved being a generalist, and I loved doing obstetrics, but I felt like this experience changed me. And so I think I was 7 years out, less than that even. And I just around that period of time. And I gave up OB to focus in this area. What started happening was I learned a lot about breast care. I did work side by side with breast surgeons, breast oncologists, plastic surgeons. My knowledge, my growth curve was really steep. But what started happening was those providers would also ask questions to me. And one of the biggest questions was, hey, my patient was thrown into menopause from chemotherapy. How do I treat them? Or other questions were, my patient's bleeding on a drug like tamoxifen. What do I do? Or my patient has vaginal dryness and sexual dysfunction as a result of all this treatment. What do I do? And I look in the literature and was shocked that there was almost nothing out there. So that now, fast forward the past 25 years, I feel very lucky to have helped develop a field that I think of as bridging breast oncology and gynecology, and really focus specifically on the quality of life, the women's health, quality of life issues that cancer survivors face. And with that, I sort of, as I gave up OB, I changed a lot of my general practice, started focusing more in menopause. And then somewhere along the line, I have mainly shifted and given up most general gynecology and focused almost solely in survivorship and menopause. So that's sort of the trajectory before I go to even where I am now, but that was my trajectory at UCSF. And I have to say UC was incredibly supportive, partly in that, when you do a field like this, you spend a lot of time with patients and it's not reimbursed well. It's not like a procedure. I certainly do procedures. I helped work with the breast care center so that we could do joint procedures together. So if someone's getting their breast surgery or reconstruction and they need their ovaries out as part of their cancer treatment, that we could combine it to be more patient-centric so they didn't have to undergo multiple procedures. But the vast majority of my day-to-day life is spent in clinic with patients, and that isn't a moneymaker. And UCSF was supportive of me developing this program. It's called the Gynecology Center for Cancer Survivors and At-Risk Women. And I really am so grateful for that because they put the resources that I needed to be able to do that. I've done research in the area, really helped develop a clinical program, went to training, have gotten as much training as I could, and then really feel like I've been able to be on the forefront of that area. Have been lucky enough to work with the American College of OB/GYN, writing some of their guidelines for managing GYN issues for breast cancer survivors. Somewhere along the line, got asked to join as its inception, the survivorship panel for the National Comprehensive Cancer Network, where I ended up chairing their menopause and co-chairing their sexual functioning panel. So have as I've grown and matured in this area, have gotten to do a lot of things nationally to help train others in this space as well.
Wow. Mindy, thank you for walking me through that whole arc. It's so interesting. We talk a lot in this podcast about these sort of epiphany moments, and often we're talking about an insight that unlocks an invention. But in this case, you listened to an epiphany that changed the whole arc of your career, and I would say even led to the genesis of cancer survivorship and gynecology as a field. And that's really incredible. I noticed you spoke about the shortcomings of Western medicine, watching what Marina was going through. I know that there's some through lines from that original observation to what you do now with Midi and some of the directions that Midi is talking about heading. I'm curious, would you be able to share a little bit more what some of those shortcomings were that you were seeing on the ground, and what some of those alternative treatments and therapies were offering Marina that sort of the standard American paradigm wasn't?
I think one of the main points is we as allopathic Western trained physicians learn a lot less about integrative therapies. I think that is changing over the past 20, 25 years. Certainly there are complementary and integrative training programs out there for people who are Western trained physicians. But if you look at supplements or botanicals or vitamins, they are not classified as drugs. So you do not have the pharma support to help do the research in this area. The financial incentives are not aligned. So we just don't have as much research in many of these integrative therapies. And I kind of look at these all together. We've got integrative therapies from things like acupuncture, behavioral therapies, mindfulness, CBTI focused on insomnia. You've got botanicals and herbs. You've got vitamins and supplements, and then certainly lifestyle things where we're learning a lot more, in fact, about the role of lifestyle like exercise in both preventing cancer, and we know for people with certain types of breast cancer that regular interval cardio decreases recurrence and improves survival. That's something that people have control over and can do. What I saw with Marina was she was doing acupuncture. That was one of the things that really alleviated pain. She had a lot of chest wall pain that really had helped out. She was doing a mix of Chinese herbs. I'd say that I certainly to this day know less about oftentimes the Chinese herbs per se, but she was doing supplements. She was particularly doing behavioral therapies like and acupuncture. And I just saw that if we open our minds and we accept that we may not have the same randomized control trial data that we do with some of the other therapies that we all think about, that doesn't mean that they aren't going to be helpful. I think her experience made me more of a holistic provider because it opened my eyes to that, and it allowed me to visualize firsthand the benefits of some of those therapies that it had directly to her, her course.
I want to come back to this. I want to hit pause on this because I do want to circle back to this theme as we talk about Midi. But first, I'm thinking maybe we could fast forward to some of your work now and to the whole Midi story. You're chief clinical officer at Midi. It is shocking to realize what a new company it is when you look at it in perspective of how huge Midi has become. I think the seed round was 2022, and last I saw the projected valuation was around $1 billion. And from your perspective, what is it that Midi saw that the rest of the world didn't see?
let me tell you what I think Midi is solving, and then I'll kind of walk you through how I got here, because this was another one of those points of never at this late of I'm pretty senior in my career did I think I would have the opportunity to be doing something as amazing as I get to do every day. So I feel so lucky to be a part of Midi. Midi realized that there was a care gap for midlife women. If you look across this country, many counties do not. Traditionally, when women go through perimenopause and menopause, they will seek out care from their OBGYN. Not always. Sometimes people see a primary care, but most often it's an OBGYN. And if you look across this country, there are many counties that don't have OBGYNs. The wait times to get into OBGYNs are oftentimes months. Training in menopause, there are a whole host of reasons, but I think many people in OBGYN do not get menopause training. People in primary care do not get menopause training. That is changing, and I think Midi is one of many reasons of raising awareness about this that is changing that. But I think that when the large NIH-sponsored trial, the Women's Health Initiative, came out in 2002, that was a large study that was designed to see whether using menopausal hormones prevented heart disease, which, as we know, is the number one cause of death in men and women. And that trial was stopped short when the finding of one arm of the trial showed it didn't prevent heart disease, but it surpassed the threshold for an increased risk of breast cancer. This was in the early 2000s, and at that point, women in this country started thinking hormones cause breast cancer. We know now that that is not true, but that was the thought. Hormones got a black box warning on them that only recently came off in the past couple months, but that scared women from using hormones, which hormones aren't for everyone, but they are for the majority of women in the perimenopause and menopause. But with that thought that hormones are bad, they cause cancer, it meant that women got the message of you shouldn't use these, just deal with the symptoms you're going through. But it also meant that anyone who is trained in women's health since 2002 was told, oh, hormones are bad, just tell women to suffer during this time. And it created this big care gap that has existed to this day. Midi actually is I was at a predecessor company before Midi that didn't make it, where I was an advisor. I'll sort of walk you through my path of how I got here. But Midi has been able to really amplify that message of we can do better. We don't need to have this care gap. There are treatment options and no one needs to suffer. And what has been amazing for me to hear is it doesn't matter where you are in this country. If you're in an urban area, rural area, women are being told the same things. We hear the same things over and over by women. Midi is now in every state. And so we hear the same things from women everywhere. And so we know this care gap is real. There's also studies that shows it takes women on average 6 different providers when they are going through menopause for someone to put the pieces together and say, oh, this could be perimenopause. Let's come up with a treatment plan that may be focused on hormonal dysfunction. That uses a lot of resources, and it's not good for the patient who has to go seek out care from all these subspecialists. So I think we've been able to really help in trying to close that care gap. And I think that's resonated with a lot of people, which is why it is amazing to me. You are correct. We launched for insurance-covered care in July of 22, and we are now seeing more than 25,000 people per week, which is that growth has been mind-boggling.
That's a huge number. Wow. I'd like to circle back to this kind of sense of, just be tough and deal with it and get through the symptoms of menopause. And putting aside how terrible that is, just that one element of messaging towards women and substandard care, and just forgetting that one part alone, for folks who are listening to this podcast who may not be medically oriented or may not be well versed in the full physiologic state of menopause. Can you just walk us through what else is happening and why, beyond being just an awful experience, sort of ignoring the symptoms of menopause, how that affects all of the other organ systems?
Yeah, I'm so glad you asked that. So what happens in menopause is essentially women are born with only so many follicles in our ovaries that produce estrogen, and essentially the ovaries stop producing estrogen and the secondary hormone called progesterone. With that, you get all of these symptoms that really disrupt your quality of life. The common ones are things like hot flashes and night sweats and mood changes and sleep difficulties and vaginal dryness and sexual dysfunction. But there are studies that say there's actually about 50 different symptoms that people may not be realize are due to hormonal dysfunction. But along with that comes increased disease risks. So the risk of heart disease is much higher in men than women until menopause, when it starts creeping up in women, and around age 65 or so, it is equal in men and women. And we know that estrogen is protective for cardiovascular disease. We know that estrogen is protective for bone loss. And menopause is the time when you see the greatest rate of bone loss, about 2 to 3% per year. And osteoporosis, or brittle bones, is a silent disease. And people don't realize they have it until they fall and they have either a spinal or a hip fracture. And if you have a hip fracture, there's a significant likelihood of dying after that. And estrogen is protective for the bones. We know that the risk of diabetes goes up. I think we're learning more and more about estrogen's impact on our metabolic health, but we see increases in diabetes. We see increases in weight, and we see that weight shifts and it becomes more what's called central adiposity as opposed to weight along the hips. And that central adiposity is actually a risk factor for cardiovascular disease. So there's a number of reasons why we see cardiovascular disease going up in women. And then the big thing that I think we know less about, but luckily there's more and more research, I think, ongoing now, is understanding the cognitive effects. There's a lot of controversy over how estrogen impacts the brain and whether it can be used to prevent or treat cognitive loss. I think there's still a lot of research that needs to be done and unanswered questions. But we know, if you look at data, women make up, I believe it's 2/3 of people in nursing homes. And a lot of that has to do also with some cognitive loss. So women live longer than men, but they have more frailty. We see more issues like cognitive loss and Alzheimer's disease. And a lot of that is related to loss of estrogen.
A massive problem, just from so many different angles.
Exactly.
You mentioned the number of touch points that a woman may encounter right now before they get the dots connected, as you put, that menopause is driving all sorts of underlying symptoms. And I know that Midi is really rapidly scaling across the country. What is the ideal patient journey? And I'm wondering if you can walk me through the experience of a woman who begins to develop early symptoms of menopause, who ideally would come to Midi, and what that journey looks like.
Yeah. Well, if I can I tell you a little bit about Midi? Because then it makes it easier to understand that patient's journey. Actually, before I even tell you Midi, I'm going to tell you a little bit about how I got there, if that's okay.
I would love that.
So, as I had mentioned before, I felt lucky at UCSF to be able to really dive into this cancer survivorship space. And in 2014, there was a group of a couple people that were doing, I know you're familiar with the biodesign program at Stanford, but a couple people, biomedical engineers, that went through the biodesign program at Stanford trying to come up with a medical device to treat a problem and have that turn into a company. They were looking at a device to treat vaginal dryness in breast cancer patients. If you do a search and looking for people out there who know about cancer survivorship it's a fairly narrow niche even till this day. So at some point my name would come up. And I was local and I was an unofficial advisor for them while they developed this. We're actually still going and trying to get an FDA approved device 11 years later. But that was my first aha moment of it's really interesting when you bring together people with different backgrounds who are really smart and try and create a common goal. And I thought, tech is really fascinating. I know nothing. I'm your basic academic doc and I know nothing about that space. But it was the first time I had sort of this aha moment of that's interesting. And then around 2018, there was a guy who was one of the founders of Color Genomics. And he was looking for sort of the next thing to do. And at that point realized that a care gap was menopause. In his prior life, he was a pathology resident at UCSF. And he came back to his pathology colleagues and said, hey, who does menopause at UCSF? And they gave him my name because I did the general GYN stuff I did was in menopause. This was a menopause company, telehealth, non-insurance covered. So people were paying out of pocket. Pre-COVID, no insurance codes for that kind of reimbursement. And that was when I had the aha moment of this is how you can do survivorship. You don't need to do survivorship for in-person visits most of the time. And if we were successful, survivorship should be a part of that company. We weren't successful for a number of reasons, but that was the predecessor to Midi. When the founders of Midi came to me, they said, in addition to menopause being this huge care gap, at some point in our conversations, and they came to me because they came to the people that were involved in this predecessor company, they said, we think cancer survivorship is an unmet need. And over the past maybe 10 years at UCSF, I had been getting a little bit frustrated that I could only see so many new patients. I could not scale what I was doing. And I realized that how lucky am I that I've been able to work with organizations like the American College of OB-GYN and the National Comprehensive Cancer Network and have an impact on a national level and help provide guidance in this area. But wouldn't it be cool if I could scale the clinical care? And I realized that opportunity existed with Midi. And we were very slow and thoughtful in our launch. And we realized that one of the things we learned from this predecessor company, the Cusp, was women want care and deserve care that is insurance covered. You may get people to initially come in, but you're only going to get a subset of the population. And if you want to democratize this kind of care, you need to be insurance covered. So Midi, I am very proud of the fact that we are insurance covered care in all 50 states. Currently, we are only covered by PPO insurance, but our goals, our long-term goals are to be on every insurance. Medicare, Medicaid, TRICARE, because then you can truly democratize this kind of care. When I joined Midi for the first year, I was actually still full-time faculty at UC. So I helped us in writing our protocols, and I still, to this day, am in charge of our protocol development. We have a whole team that goes into that, though, now. I was brought on to be our chief clinical officer when I joined. I'm still very part-time at UC, but my full-time job is Midi. And when I joined full-time, I was brought on as our chief clinical officer, but we also have a chief medical officer who's an incredible doc, Dr. Kathleen Jordan, and she's a internist infectious disease doc. And a number of our leadership team is internal medicine trained, and some of our leadership team is OB-GYN trained, naturopathic physicians, and that allowed us to develop protocols that cross-cover both women's health, typical OB-GYN, things that someone would see in OB-GYN, and primary care. And what we realized is, and this gets back to your original question of walk me through a patient's journey, is someone may come in to you for things like, I'm having hot flashes, I'm having night sweats, I'm having sleep difficulties and weight changes. And we may be able to optimize some of those things with, let's say, hormone therapy, which we do a lot. But we don't necessarily fix all of the complaints that they have. And people still have weight problems, and they still have sleep difficulties. And women have things like thyroid disease and bone loss. We've already talked about UC bone loss. And so we realize that what Midi should become is more of a health hub for midlife women. And so that journey that we walk people on is initially they come in for specific complaints. And typically we talk about doing hormonal optimization to people in the perimenopause or menopause. But then we know that there are access problems for primary care. We are not trying to replace people's primary care physicians or their OBGYNs. There are still times you need in-person care, but there are plenty of things that we can sort of supplement. For example, we have protocols in prediabetes. We send people for labs, and we've diagnosed a heck of a lot of prediabetes. But diabetes care, that's not something that we can do. We're not in person. So we will then refer to someone's primary. But I think we're able to realize that there's a lot you can do over telehealth. And one of the things that has been a physician since I joined Midi, and I am a better physician because I know so many aspects of primary care. And in my prior practice, I was pretty quick if someone said they had a hair complaint to send them to dermatology, or they had a weight complaint, and I may tell them some superficial stuff and then send them off to primary care. And now I have evidence-based information to share with them. On top of we have all of the integrative and supplements and botanicals that I have learned where evidence exists. And so I am a way more holistic provider, and that just makes me, I feel really lucky to be able to get to this point. The average Midi patient sees us 3 or 4 times a year and may be focused on different things. We have management in all of the traditional women's health areas in many aspects of primary care. We have a weight management program. We also have launched an Age Well, looking at aspects of longevity. And then what we do is we partner with large health systems. So there's a number of large health systems across this country that we have partnered with, that we can send our patients for when they need in-person care, whether that's blood tests or mammograms or colonoscopies or primary care, GYNs, subspecialty care like cardiology, neurology, oncology. We've diagnosed a lot of breast cancer. So we've grown in that way. And then Midi, now one of the other ways that we have also grown our practice is we have a whole commercial team, and we are a covered benefit for large employers, so big companies. We have been able to become a health benefit.
Wow. So many insights that you and Midi clearly sort of picked up along the way and folded into the offerings and made for an even stronger product. And honestly, even the decision to make sure that this was rolled out as an insurance accepted company, I see that as a stakeholder insight. You know, I could easily see the temptation for a strong unmet need with a large audience that's eager to pay, leading to a company trying to scale a pure concierge model the whole way. And not only did this lead to a product that's better for more people, but I think it sounds like it became a real unlock.
Yeah, I mean, you don't solve the care gap if you're only providing concierge medicine. It's hard. It is hard to grow a company like this, have it be, we're negotiating for large insurance contracts. And this is not an easy task to do. Along with growing like this, you have to ensure that your providers have support. It's not the same way that you're in a brick and mortar practice and you can walk down the hall and say, hey, I have a consult. We had to figure out how we provide support for our providers. We have to ensure the same as any medical practice that our patients are satisfied and that we have high satisfaction scores. And as you know, there's a lot of people in traditional medicine nowadays that have burnout. And we are also really trying to work on utilizing tech to minimize some of the burnout that you see in traditional medicine. So, but all of that is hard. This is not easy, and we are still growing and constantly iterating on what we're doing. What I have learned a lot by being at a company like this that's a little bit different or very different from what I have found in my experience at a big academic center is you're able to pivot quicker. So you can try things out, and when they don't work, it's easier in a tech environment. You have to pivot if you're going to be successful. And I think in some of the big academic medical centers, particularly, there's a lot of layers that it's hard to pivot so quickly. I think we have been able to grow and be as successful as we are, although we are not yet profitable. We are growing and scaling and continually trying to do better and figure out how to provide this care to more and more people and get better insurance coverage and expand our insurance coverage. But as I said, it takes a lot. I think our leadership has hired incredibly talented people. People have this vision and really drive to have us be successful. It's just, like I said, I feel so lucky to be on this amazing journey, and I have learned a ton, and I continue to learn every day. But to your point, I think that we've grown as much as we have because what we are providing is resonating with women across this country. And then for me personally, I'm hoping that in 2026, we're going to launch cancer survivorship as a truly separate visit type. And that was my goals for joining, to be able to scale survivorship care. So again, I feel lucky that I'm getting to live my career and academic dreams.
I'm so glad you touched on the possible cancer survivorship clinic visit coming up, because my final question for you was, as you look to the horizon in your career, but where you see and are expecting Midi to head, what is your dream for the fully realized version of Midi down the road, and what that will look like?
Well, I'll answer that part, but I'll also answer, I do have other hopes and dreams on the academic side. So part of my reason for still being a little bit at UCSF is because I do see patients at Midi, some patients, not many. I enjoy seeing a few patients at UCSF, but I am really trying to help get these fellowships off the ground, which to train more people like me, so that as people go through medical training, if this is an interest, that more and more people can be trained in the area so that we fill some of the gap in having leaders who know this space and educators who know this space who can help train the next generation. So on the academic side, my goals are to help other institutions. There's a few places that have either fellowships somewhat like this or have things in the work to develop this. On the Midi side, what I am really wanting to do is help scale this care for the individual patients. I think a lot of cancer survivors get told, be thankful you're alive and just deal with some of the side effects of treatment. And we are really trying hard to change that message. No matter what you are going through, if you are a average or healthy perimenopause or menopausal patient, or if you are a cancer patient or a prior history of cancer that got thrown into menopause from your treatments, absolutely no one should have to suffer. There are treatment options for virtually all symptoms, and people should know that, providers should know that and know what to do. And at Midi, we have right now a cadre of about almost 600 providers that are being trained in these areas. We have extensive training. When I was talking about the supports we have to do to ensure they have ongoing training, we have our version of Grand Rounds that is accredited for our providers, so they get credit for the education that we do. We have all these drop-in rooms to ensure that they are continually getting up-to-date information, whether you are, again, perimenopause, menopause, on that traditional journey or you've been thrown into this from cancer survivorship. I meant from cancer treatment. So my long-term goals are that no one with cancer in this country should be told you have to suffer. There are treatment options for everyone. We are hoping to expand that message everywhere. I think one of the other reasons that Midi is resonating with a lot of people is I talk about one of our special or sweet sauce. And if you are a large guiding organization in this country, American Medical Association, American College of OB-GYN, or the Menopause Society, many times I think you wait for the many years it takes to do a randomized controlled trial for evidence to be confirmed. Yep, this is clearly what we know from a randomized controlled trial. And then large insurers use that public statement to decide what they're covering for care. What we have learned as Midi has grown is women no longer want to wait the 10 to 20 years for a randomized controlled trial. And research is coming out all the time. And they're coming in saying, hey, I read about this. Does that apply to me? And I think one of the reasons we are resonating is we take evolving evidence and we incorporate that evolving evidence into our care protocols and use that in shared decision-making with our patients. And I think that that is a message that is really resonating with a lot of people. I do feel like on the forefront as medicine is changing, but we're willing to have those conversations and say to someone, look, we don't have randomized controlled trial evidence yet. We may not know this for sure, but let's tell you what we know. Let's tell you the gaps in the literature, and then let's help come up with a treatment plan that is right for you as an individual. And I think that message a lot of people are hearing and is helping us expand as much as we have.
It's so striking how the shared decision making, I mean, the real gap between what you're doing and the way that I could see this not being executed correctly is that you are sharing what you know, what you don't know, and creating a discussion with your patients that really sort of brings in their comfort with the amount of knowledge and how to make decisions. Mindy, this has been so special talking to you today. I'd love to know where would you like people to go to learn more about you and learn more about what Midi Health does?
Yeah, come to us at Join Midi. It's very easy. If you look up menopause as a search, I think we come up pretty high, if not at the very top of the list. But joinmidi.com. It's really quick and easy. People within a few minutes can put in their insurance, figure out if we are a covered benefit. And we also put out a lot of educational information for the public. So certainly research our site, look at some of the information, and then decide if we are a place that you'd like to get care. But I'm so happy. Thank you for asking me these questions and letting me join you today.
Oh, this has been such a treat. Thank you so much.